Hello, my name is Dr. Nicholas Walsh and I'm a lecturer in the School of Psychology at the University of East Anglia, and it's my pleasure to talk to you today about understanding psychopathology and mental health. So using the term psychopathology already sets a certain context or sets a certain perspective on the subject matter that we're talking about today, whereas the term mental health is arguably broader and has less of a connotation or fit within a certain discipline. And what I mean by this, I'll talk about in the next few slides. So, as a quick overview for my talk, I want to talk about mental health conceptualization. So, what do we mean by psychopathology or mental health? What kind of thing is a insert blank here? Are we talking about a condition, some kind of way of being, some kind of disease, etc.? And we'll come to that in a moment. And then how are things formalized within classification systems that have some kind of utility within society? And we'll talk a bit about that. And then, do people just present with some kind of mental health problem or mental health difficulty or condition or complaint? Or does it develop over time? And if so, is there some cause for this kind of condition? And what are the mechanisms by which such things may occur? And we'll talk a little bit about that. And then, given what we've talked about causes and mechanisms, what's the best way to intervene? And a popular way to intervene is through psychotherapy, and I'll say a little bit about that, and then touch on other kinds of mental health treatments and interventions. And then, do we focus too much on the negative with regards to mental health or psychopathology? And is it helpful to understand other areas of psychology, such as humanistic psychology, or more recently, positive psychology movements, and what is well-being in general? And then finally, I'll touch on student and young people's mental health, because this is such an important topic, and I think what I say may be relevant and of interest to many of you here today. Finally, at the end, I'm going to introduce a debate, and this is using a tool called Kialu.edu, and I'll show you a video about that and give you a little bit of a talk about it. And I'm hoping in the time in between watching this video and then us meeting again for the Channel Talent session, you might want to engage with this either as part of your class or individually like that. And I think that'll be a really nice learning tool. Okay, so I'm really interested. Are you studying psychology at A level? And I ask about this because I know a little bit about the syllabus, the textbooks, and what the content is covered. And when you study at university, you're able to go into things in a broader detail and maybe challenge some of the things that you might cover at A level. And I think that's really interesting. And hopefully some of the things I say in this talk may make you reflect differently on the meaning of what is covered at A level. And again, we can discuss this when we meet. So things change all the time. What you see in textbooks is often, a popular way of thinking about things, or the dominant way of thinking about things at one point in time. But through research and greater societal discussion, things change. And one of the things that's changing is how we talk about mental health, mental health conditions, mental health disorders, etc. And whether the way we talk about it is the best way to talk about it. And is the way we talk about it as inclusive, as valid, as explanatory, as it could be, or should things change? And at the moment, within the field of mental health, there's a big discussion about how we talk about mental health conditions and the language we use. So, for example, in the case of autism, do we say, I am a person with autism? So we use person first language. So it's something you have, like a mental health condition or like a medical illness that might come and go. So I have a cold, or I have a episode of COVID, or I have heart disease, and it's something that can be treated, and then you can take it away from the person and then you don't have it. Or should we use identity first language? So you say, I am autistic. In this case, mental health is something someone is. So it's like a trait, it's part of them. And if you take that away, then maybe you're taking away part of their personality or their character. And obviously that can be quite we wouldn't want to do that for many people. And these ideas come from a well-known book within psychiatry. It was well known a few years ago, and whether it's read again now because it came out in 1998, the second edition. And I really like it because it discusses mental health conditions, mental health phenomena, ways of being, etc., within different perspectives. And I'll just briefly touch on these. So one perspective is known as the disease perspective. So within medicine, a disease is something that you can look at either with a scan or some kind of clinical test. And in this perspective, mental health is something someone has. So they would have a mental health disorder. Okay, and this can be treated, and arguably there's unique causes and unique treatments for a specific condition. An alternative perspective is to say, mental health is something someone is, and it's some kind of trait, maybe a spectrum that we all vary on, and maybe the extremes of the spectrum are where the interesting, points are, or where we need to intervene and do something about. So it's just an alternative perspective that says, rather than having people in a category or a type, you say it's a dimension, something that we all vary on, and so we all vary at the point of the dimension. Another perspective is a behavioural perspective. So you might have, say, antisocial behaviour that someone conducts, and clinical psychologists would say, we would look at these feedback loops that are ongoing. And in this case, so mental health is something a patient does. And the final perspective is known as the life story perspective. And it's really about what kind of experiences someone has. So how someone feels at a particular point in time is an understandable response to maybe what's happened to them before, in their life, what they've encountered, what kind of life experiences they've had. So it's not really a medical problem per se. It's more maybe an adaptational problem, how they adjust to certain difficulties and make sense of these difficulties that might cause problems for them at that, particular point in time. Okay, so going back from the word psychopathology, the word pathology is a medical term, and it means the science of the causes and effects of diseases. Okay, and you might have pathology that you can detect with a clinical test, such as like a lesion in the brain. An example of this is this picture here. So neurology is all about disease of the brain, so pathology of the brain. And this is a picture of an individual with glioblastoma, which is a type of brain cancer. And here you can clearly see there is a difference. There's something wrong. There's something going on in the brain. And maybe there's different kinds of glioblastoma, and maybe different kinds of, these lesions or these sort of marks on the brain might respond to different treatments, or there might be particular causes. So in medicine and neurology, you want to come up with like a taxonomy or a classification system to identify these different diseases of the brain, and then work out, this can inform treatments and interventions. So psychopathology, if we extend this, it could mean disease of the mind. But this fits within this medical context. Other ways of thinking about it might be more broad, such as mental health, or you might talk about an issue someone has at a particular point in time, or a disorder, a problem of living or in some area of their life, illness, which is maybe the subjective experience of sickness, or a problem. Maybe there's no physical or clear test or thing that you can detect on a scan, like a disease, but maybe it's something more subjective. Or you could use a broader term like condition, which is maybe more of a catch-all term, or you might have older terms that may be outdated, like malady, or in other words, where you say like a difference from normal, abnormality. So to say a bit more about this medical perspective, in psychiatry and mental health, we talk about psychopathology, and in the same way neurology might have identifiable diseases that can be detected with scans or clinical tests. In psychiatry, there's a classification system known as the Diagnostic Statistical Manual of Mental Disorders, and it lists different kinds of arguably identifiable or differentiated mental disorders. And then psychiatrists or other mental health professionals try to identify the particular disorder that an individual has or presents with, and then they can administer or prescribe certain interventions or treatments that go with that. In Europe, we use something called the International Classification of Diseases, the ICD, and we're now in the 11th version. And what these classification systems do, so as I said, they lay out separate identifiable categories that individuals would present with or could be diagnosed with. And so you've got different things here like schizophrenia, anxiety disorders, depressive disorders, personality disorders, a whole range of different disorders like that. And then you've got subtypes that go with these things. And basically the aim of the game in psychiatry is to identify the different disorders that an individual presents with. Usually people try and put people into one particular box or one particular category, but this is challenging because often things are messy and things overlap, and you get the term comorbidity when people present with maybe or are diagnosed with multiple disorders, or you can use the term multimorbidity when people are diagnosed with multiple disorders. And so a challenge is to say, well, is this the best way to identify people? To put people into individual boxes, or should we come up with an alternative system that maybe embraces this comorbidity and this diversity, this heterogeneity that people present with? So using this trait approach to say individuals vary on many kinds of traits. So you might have traits for intelligence that you might have studied at psychology A level, or traits to do with a whole range of constructs that we look at in psychology, like creativity or personality. So we have the 5-factor model of personality that argues that people vary on 5 different dimensions. So that's the Ocean framework that you might have heard about. So a similar kind of approach has recently been developed for psychopathology or mental health, where you can look at huge numbers of individuals and you can look at the signs and symptoms that they present with and see, is there any kind of overlap that people might present with? Can we put people into boxes, or is the boxes the right way to classify people? Or rather, is there a different kind of structure that might be the best way to characterize psychopathology? And what's been developed is this hierarchical taxonomy of psychopathology system, the HiTOP. And what this system has found is that certain things tend to go together, or certain conditions or signs and symptoms, ways of being, whatever you want to talk about it. So if people tend to demonstrate distress or fear or anxiety type emotions or cognitions or behaviors, these would be categorized under internalizing type disorders or spectra within this system. If you maybe present with hallucinations or delusions or thought disorder, you might be then classified under this psychosis type spectra. Or if you experience externalizing things, and these are things like substance use, antisocial behavior, conduct disorder, these would then get labeled under this broader term, externalizing. And at the top, there's thought to be this factor called the P factor, which is called the psychopathology factor, which is thought to be a general variable which might statistically underlie a lot of these different things that you see on the surface, like these symptoms or these traits that are measured. And these things are measured with questionnaires or interviews, anything really where you can quantitatively measure some kind of indicator. And what this is quite a controversial system, because the arrows show that maybe this P factor causes the things that we see on the surface. And much research is going on to say, what is this P factor? Because at the moment it's a statistical thing, but is there a way to understand it in reality? Maybe it's to do with like how big your brain is or how your brain works, or other kinds of things like that. But what these things do, they talk about things in a static way. So these categories or traits are something which you probably are put in and thought to have over the course of your lifetime. And other approaches seek to move away from these static conceptualizations to look at things dynamically. So one is something called psychological formulation, and this is the kind of approach which informs cognitive behavioral therapy, or CBT. And rather than talking about things in terms of something someone has or is, it talks about feedback loops and patterns of behavior or patterns of thinking that individuals might demonstrate, which might be problematic or unsustainable and lead to other problems in their life. So to give an example here, you've got a vicious circle of somebody feeling depressed in the first instance, and then this then leads to them having negative thoughts about themselves or the future or the world in general, and certain expectations. So they might expect no fun to happen, and consequently they may do little. And if they do little, if they don't leave the house, they may not experience social rewards, or the things we do to obtain, work in society and gain rewards or pleasure, meeting other people, doing fun activities, fun hobbies. And then consequently, the individual may feel further depressed. What's interesting, it's quite difficult to separate out cause and effect in these formulations. So there's something called circular causality, which is a way of thinking about these vicious circles. And you might have in other domains, so there's examples here about chronic pain or relationship problems or social anxiety. And this is, as I've said, something called, or something understood via psychological formulation. So rather than making a diagnosis that you would do in medicine, you conduct a formulation. There's a bit of debate about whether they can co-occur or they're different things, but I'll leave that for today. And what you do, you tend to understand the presenting issues. So when did this first begin? What are the problems? The precipitating factors, like does anything trigger this? Perpetuating factors, like does anything maintain the problem? Predisposing factors, are there any risk factors perhaps for the individual? Maybe sort of unemployment or lack of money or family issues, things like that, or any protective factors, anything that enables resiliency and strength to help the person maintain emotional health through any difficulties. And the way this works in practice, rather than doing a clinical interview, you would do this psychological formulation where you would, you can list the different problems that individuals have, you can list the different triggers and develop these kind of feedback-based models where different things to connect to different things, and you get a better understanding of the dynamics of a particular problem. So I mentioned before this life story approach. So you would say rather than someone having a disorder or a medical problem, rather how they behave is, or how they think or how they feel is maybe they're not really adapted to life. There's a problem with their life story. And this is where you might have narrative type therapies to help people best understand what's happened to them, what kind of experiences they've had, and to allow them to make sense of these things. Okay, and if they can understand the story, they can then best understand how to maybe edit that story or have a greater understanding, greater insight, and maybe do things differently in the future. And this might relate to the kind of roles they have in their family or how they interact with other people in society. As an extension of this, there's something called transactional analysis. And I think this is really interesting, where rather than saying someone has a disorder, you might say they've learned through patterns of behavior certain roles or ways to behave in different situations. So there may be different roles that people have in relationships. And in the short term, this might be helpful, or it may be due to attachment patterns or ways that you've grown or you developed growing up. But maybe it's problematic in the long term or leads to unsustainable systems. So I'll give an example of this thing called the drama triangle. So the drama triangle was developed, I think, in the 1950s, 1960s, and it's part of a system called transaction analysis that aims to understand different relationships or transactions in relationships among people. So say you've got the washing up building up in the house. Your brother or sister may say, oh, it's your turn to do the washing up. You never do it. It's always me doing it. And you might say, oh, poor me. Why are you having a go at me? Don't blame me for these things. So you may be in the role, not on purpose, but you may be in the role of the victim here, and you may view the other person as a persecutor. And in order to maintain harmony within the household, somebody, either you or your sister or brother, would have to do the washing up and say, okay, I'll do it this time, but you'll do it out of obligation, you'll resent doing it, and in the short term things will get done, but that's not normally a sustainable position. And you may then switch back to one of the other things when it kicks off again, and the drama continues. And you see this drama triangle all the time on reality TV shows like Married at First Sight or all the TV programs basically. And it makes for engrossing viewing, but you can see it. But an aim of particular kinds of counselling or psychotherapy is to understand these roles that people might have or their part in it. So one thing to think about might be more positive roles that people might have. But there's another thing called the sick role, and this is something that pops up in all kinds of societies where when someone's sick, either they get COVID or a cold, they get relief from their responsibilities in society. And arguably, when you get diagnosed with a mental health condition or mental health disorder, you get put in this sick role. And it may lead to people thinking, well, I can't do this because of my anxiety, or I can't do this because of my disorder. And if you understand things within the medical perspective, then this might lead to certain outcomes in how you behave. Whereas, if you were to view it in a different perspective, maybe in the psychological perspective or behavioral or life story, you may say, well, actually, there are things I can do to change the patterns of behavior or change my understanding of the narrative I have about my behavior. It may be that actually there is a legitimate reason for people being in the sick role, and it is important that they are asked to, relieved from certain responsibilities, because it's unfair to ask people to do things that they can't do. But this is like one of the big controversies in psychiatry and mental health about, because there may not be clinical tests to say someone has a mental health condition, then how do you decide whether someone should be in a sick role or not? And the different ways of thinking about things is known as a paradigm. And paradigms, represent assumptions, concepts, theories, models that guide how we understand or conceptualize certain phenomena. And what's interesting is how these different paradigms, affect subsequent implications of these conceptualizations. And in the context of mental health, maybe if you think mental health is or should be viewed within a medical conceptualization, this would then say, well, the treatments should also be, within medicine. So you might say, well, for a mental health condition, individuals should be prescribed medications. And perhaps if you view it within a psychological or behavioral perspective, you might say, well, actually, we should treat people via psychotherapy and things like that. And so basically the assumptions that we have lead to implications for practice, how we practice mental health or psychiatry, but also implications for policy and how we talk about mental health phenomena in the wider world. Do we use the term conditions, or do we use another term like maybe adjustments or adaptation or challenges that people have had or problems? And this is a matter of big debate because we don't want to medicalize things, but we also don't want to under-medicalize things and ignore problems that should be or should have intervention through medical systems. And so basically, if you present with certain problems, if you're experiencing certain things, you may then go down a route where you see your GP, who may prescribe you medication, or you may then get referred to a psychiatrist, or you may go see a mental health professional like a clinical psychologist, who may do a psychological formulation and go through CBT with you, cognitive behavioral therapy, or some other kind of psychotherapy. Or even you may see a life coach and they would do something completely different. And they might say, well, maybe we should focus on your skills or your personal growth or other concepts that we talk about within positive psychology. And I'll come to those in a sec. But it's interesting to think about these different interventions. So, and because our understanding of these things has changed over time. So previously, it was thought that individuals who presented, say, with feeling depressed, feeling lack of pleasure from life, who would receive a diagnosis of major depressive disorder, this is due to a chemical imbalance. And so medication needs to be prescribed, maybe in the same way you prescribe medication for diabetes, to correct this chemical imbalance. And so this has a big impact on, there's advertisements about this in magazines or television. It has a big impact on the public's understanding of mental health and perhaps the stigma attached to it. So then we say the term, we should think of mental illness as an illness like any other. But also, debates about how do we use psychotherapy? Do we work on maybe dysfunctional beliefs that individuals have, or maybe is it down to something like being able to talk to somebody about your problems who has empathy for you and allows you to develop better understanding and insight into your experiences or your own life. So another thing to say is that medicine, taking this medical perspective, arguably brings people back to some kind of baseline where you're healthy or you don't have some kind of illness. And it basically, that's the aim of medicine, to allow recovery, intervention, people to feel better, feel themselves. But what medicine doesn't tend to do is focus on things like allowing people to increase their degree of health, if that is possible, their resources, and allow them to grow and flourish. And arguably this has been a focus of an area of psychology called positive psychology. And positive psychology came around at the end of the 1990s. And it developed from humanistic psychology, so psychologists like Abraham Maslow, who came up with his hierarchy of needs, or Rogers and his work in humanistic psychology. This earlier work was largely qualitative, and didn't really use modern scientific methods. And Martin Seligman was a clinical psychologist, or is a clinical psychologist, and at the end of the 1990s, he became president of the American Psychological Association, and he wanted to shift the focus in psychology and psychiatry as well, away from the negative, saying we focus too much on people's problems or the difficulties. We should focus on developing people's strengths or allow them to grow, because doing this will develop the positive qualities of the individual and develop traits like optimism or courage, future-mindedness and skills, etc. And all these things will improve the world for everybody. And this is filtered through. So nowadays we talk about things like interventions that we can do to lift people up, maybe to improve their grit or their sense of flow or their autonomy, to allow them to flourish. And so there's apps you can get for your phone. You can buy these journals where you can write down inspiring quotes, talk about things that you're grateful for, things that went well that day, or things that would make your day go well, or affirmations. And the idea is that doing these things will lead to greater success in life. And all this stuff, part of this is going to university and things like that. However, what we've noticed is this maybe greater focus on the individual, improving their skills, improving themselves, becoming a better person, has led to a big increase in what we call socially prescribed perfectionism. So this is where individuals have endorsed over the years, and we can see this because we've given out questionnaires, or studies have given out questionnaires to different groups of individuals, but using the same questionnaire. And we've seen there's been a big change in socially prescribed perfectionism since around 2005 to 2010, and it seems to be increasing since then. And socially prescribed perfectionism is when you say, I feel this pressure from the external world, from other people to do well. Everyone else is perfect and they're judging me if I'm not perfect too. People tend to get upset with me if I don't do things perfectly. Everyone expects me to be perfect. And we're not sure why this is. Is it due to social media around this time, and apps like Instagram or Facebook, and you're seeing yourself compared to other people, and there's this compare and despair, or FOMO, fear of missing out. Or it could be due to other impacts, so the financial crisis of 2008, and then the impacts of austerity and the changes there, and this pressure on people to do well in a difficult society. We're not sure. But what we're seeing now in American universities and in the UK, around the world, we're saying that this perfectionism is associated with anxiety, where anxiety is destroying individuals' well-being. And people are saying you're not happy enough, you need to do better in life. And this anxiety, we're able to measure this, and because of maybe the medical approach, where we can measure things through epidemiology, which is basically counting how much disorder is out there in society. And what we're finding now is that anxiety rates seem to be increasing, particularly for young females. And again, we're not sure why this is. Is it related to social media? Is it related to school pressure? Is it related to other aspects in society? There's lots of things that have happened, and it's quite difficult to disentangle them all. And people have argued now that young people growing up are an anxious generation, arguably different from previous generations, maybe the generations that I'm in, or when I grew up. It's very, it's a matter of much debate. There's other people arguing other explanations for this. But, the data is clear that there does seem to be a big increase in anxiety for young people, particularly young females. It may be that males don't tend to report how they're feeling, and so they feel they might go under the radar. But what we are finding now is who reports bad mental health or psychopathology is not random. Obviously, everyone can experience bad mental health, and we should increase awareness and support and resources for all people. But what we're finding now is that bad mental health tends to cluster geographically around the country, and particularly in areas where there's high social deprivation. So you can develop these indexes based on multiple different measures. So as we can see here then, parts of the coastal areas, Norfolk, Lincolnshire, the North East, parts of the Midlands, these are the areas that tend to show worse mental health. And so arguably, rather than thinking of things in terms of like a medical problem, which is maybe what are the social factors which might be driving this. So psychiatry is arguably in a time of crisis where there's much debate about what is the best perspective to adopt when discussing psychopathology or mental health phenomena. People have written about this, books have been written, and it's a really interesting time to study psychology because we don't know the answer. There's no agreement, and maybe a new system may be developed which might allow for different perspectives to be incorporated at the same time. But it does, so we've got this picture of the koala here, and if you just focus on the signs and the symptoms that the individual has or the koala has, you may say they're exhibiting some kind of disorder. However, what they're neglecting, arguably within a medical perspective, is the broader context where the environment's changed and the environment is no longer able to allow the koala to function or gain reward from the environment. And maybe in mental health, maybe in psychology, we don't tend to do that. And we should do more of that. So the big question is, how can psychology save the world over the next century? Is just focusing on the individual, maybe at the expense of the broader context, the way to go? Or should psychology become more interdisciplinary or multidisciplinary? Should we incorporate information, research from other areas like sociology or economics or environmental sciences, all these different things? So what's the best way to understand mental health and psychopathology within the next century, and is psychology the way to go? So I teach this in my module, and students tend to enjoy it. They find the formalization and conceptualizing part quite difficult, but they do find that it's changed their beliefs about mental health. So maybe we should maybe update or talk about different ways of teaching psychology rather than the way we do in A-level or at the start of university. But my students tend to really enjoy this, and seeing things differently kind of opens their eyes to these different perspectives, and I think that's a really valuable thing. So what I'm really keen to do is kind of capture everyone's different perspectives on this. And a way to do this is through a new tool called kialu.edu that I've been using in my teaching. What I'd like to do is have people, either as a class or individually, hopefully the teachers can kind of talk about how they'd like to run this. Individuals would talk about pros and cons, or debate the pros and cons of this thesis. So the medical concept of mental disorder should be abandoned, and people can write down, yes, I agree, it should be abandoned, or no, it shouldn't be abandoned, and list the reasons why. And you can vote on this, and the tool allows you to vote, and together we'll have a really nice, engrossing, engaging debate, and hopefully capture the diversity of opinions or thoughts or beliefs or understandings, conceptualizations regarding mental health and mental disorders. So to take part in this, please use this QR code or use the link to the website provided here. And I look forward to discussing this more with you. I can answer any of your questions. We can go into further detail on anything I've talked about today. But I'm really looking forward to the session, and thank you for your attention today.